Chapter 20, the periodontal examination. After studying this chapter, the student will be able to describe the components of a comprehensive periodontal examination, list the instruments used for a periodontal examination, explain the technique for use of the periodontal probe and explorers, and explain how the procedure for comprehensive examination will be described to the patient. All right, basic examination, we have mouth mirror, explorers, periodontal probes, and the air water syringe. So let's get my laser pointer here. Right here is our mouth mirror. Down here, go ahead and write on your slides at home. This is the 1112 explorer, and that is our periodontal explorer, our calculus detection explorer. And then we have the periodontal probe, and that is right here. Okay, this is kind of our basic three here. We have a periodontal probe, our mouth mirror, and then this right here looks like a single-ended shepherd hook explorer. Then we have our air water syringe, and this here is the syringe, and then these are the syringe tips that the air and water come out of. You'll see we have two different buttons. This one here is for air, this one here is for water. Okay, the mouth mirror. Description, let's talk about the parts. The mirror has three parts: the handle, the shank, and working end. And you're going to learn a little bit more about that in pre-clinic, okay? But we will go over a little here also. The types of mirror surfaces, we have plane, which is flat and may produce a double image. Then we have concave, which helps magnify the surfaces that you're looking at. And then we have front surface. The reflecting surface is on the front of the lens rather than the back as the plate or magnifying mirrors. The front surface eliminates ghost images. It also is available as a double-sided mirror head. Okay. Now diameters, mirror diameters vary. So you can get the smaller heads and the larger heads. Don't hang yourself up too much on the sizes of those. You'll never be asked. Just know there are different sizes, and so in your office you may want to get a larger or a smaller, or have a variety so that you can reach different areas and different patients' mouths. As far as attachments, mirrors may be threaded, so you kind of screw it in to the cone socket, or screw it into the handle, or they can be cone socket, which it's joined to the handle. Because mirrors tend to become scratched, replacement of the working end is possible without purchasing a whole new mirror. So you'll see in pre-clinic we'll get our mirror heads and our mirror handles come separately, which is quite nice. Handles, you can have thicker handles, and those are going to contribute to a little more ergonomically comfortable grasp, and you're going to have a little more control with those. And then the lightweight handles helps decrease finger fatigue, and you're going to get that a lot more in pre-clinic again. And then we have disposable mirrors, and disposable mirrors are basically for patient instruction. Sometimes you can send them home with the patient. I know I use disposable mirrors when you're in community settings, going out into a community, so you don't have to sterilize them all the time. I used them for my research paper, or for my thesis, when I was gathering my data out in community settings. So they can take them home and take a look at their mouth. It's kind of nice to have a couple on hand in the office if you see a lesion or you see something in somebody's mouth, to help them visualize what you're seeing. All right, and then we're going to learn our purposes, uses, and procedures for use here, but let's go a little bit into our parts of the instrument, parts of the mirror here. Okay, so here's the mirror, and you'll see this is the head, okay? So that's considered your working end, okay? B is considered the shank, and A is considered the handle. Now it changes a little bit. It's not quite as cut and dry when we get to our instruments. You'll see here's the working end, here's the shank, and here's the handle. So it's not as clearly defined as the mouth mirror is. Okay, let's go into the purposes and uses of the mouth mirror. We have indirect vision, which helps you see the surfaces that you can't see directly. So you're going to be looking through a mirror. It's kind of like if you want to see the back of your hair, you hold a mirror up and behind, and then it reflects into the mirror in front of you, right? So that's what we're doing here. And then we have indirect illumination, and that's where maybe an area of the mouth is too dark, so you're going to kind of reflect the light off of your mirror and use it as kind of a flashlight to the tissues. Then we have transillumination, and that's where you're kind of redirecting the light or reflecting the light. That's what they're doing in this picture here. They're reflecting the light to go through the teeth, and so because dental caries, the translucency of enamel isn't as evident with caries. So when you reflect light, you're going to see more of a dull area rather than that translucency if there's decay starting in between those teeth. And then we have retraction, and that's where the mirror is used to either protect or prevent interference of the cheek or lips or tongue. You can see here is the cheek, and there they're retracting the tongue, keeping it from that area. Let's talk about the air-water syringe. So this is going to be a great tool for many different reasons. It's not just that we have air and water, it's just air and water can do so many things for us. So purposes and uses: with appropriate timely application of air to clear saliva and debris or dry tooth surfaces, the following can be accomplished. First, it's going to improve and facilitate the examination procedures. So we're going to dry the calculus, and as you can see in this picture, you can see all of this calculus here, and it becomes really evident when it's dry. When it's wet, it looks a little more tooth colored and is harder to see. But also, it's going to help deflect the gingival margin. So when you blow air here, you can see a little bit subgingival. You can also see if there's any decay along that gingival margin. Again, it can help identify areas of demineralization, those white spot lesions at their earliest stages. It's also going to help see any caries lesion easily. Hold on. Okay. We're going to be able to recognize location and condition of restorations, particularly tooth-colored restorations, because they do get a little difficult to see, and you'll notice that the crystals of the tooth, when dried, look very different from the structures or the bonding of a composite. Let's see here. So also improve visibility of the treatment area. Dry the area for finger rest to provide stability during instrumentation. To facilitate a positive effect scaling techniques. Minimize appointment times. Evaluate complete removal of supragingival calculus like we talked about. It's going to prepare the teeth and gingiva excuse me, Got a little bit of a cold here today. So it's also going to prepare the, sorry, this isn't working for me. The teeth and gingiva for certain procedures. Sorry about that. Examples would be drying the surface to apply caries preventive agents such as fluoride. Also to prepare for taking impressions and for applying topical anesthetic. So there's lots of times where you need to have the area very dry as a hygienist. Now our compressed air, the description, we'll start with that. Air source, it is an air compressor with tubing attachment to the syringe. We do need an air tip, and they are angled, so you can turn it up for the maxillary and down for the mandibular. And it doesn't go all the way up or all the way down. It kind of goes at an angle. And you'll kind of get that over time, how to angle that. Procedures for use, you're going to use a palm grasp to hold it. And that means you're going to be wrapping your whole hand around it. You're going to test the airflow always before you put it in the mouth, because you want to be able to control the flow of the air, especially if the patient has sensitivity in their mouth. But also, if you test it outside the mouth, if that tip isn't all the way in, you would rather it blow off onto the tray rather than into the patient's mouth. So you want to make controlled, relatively short, gentle applications of air. Supplement air drying with the use of the saliva ejector or folded gauze can also be used. So just know that you want to use it very gently. You don't want to just dehydrate that tooth really fast, especially if they have sensitivity. Now, precautions, we want to avoid sharp blasts of air on sensitive areas. Also, we want to avoid the forceful application of air, which can direct saliva and debris out of the oral cavity, and then you're going to contaminate your working area, right? Air directed towards the posterior region of the patient's mouth can cause coughing, so you need to be careful of that, because if you need it dry and then they start coughing, they're going to end up closing their mouth when they're done coughing and contaminate that area again. Also, avoid startling the patient, so you want to give them a warning that you're going to dry the tooth. Okay, so grasp and rest, modified pen grasp with non-dominant hand, fulcrum or rest for stability. Fulcrum is just kind of, if you look here, see how they have a finger rested on a tooth? That's a fulcrum. So it's going to give you, it's kind of the foundation for your instrumentation. Okay, you have to have a really strong fulcrum, especially when you're removing really hard calculus, because without that fulcrum, you're going to slip off the tooth and injure the patient. So it's very important that you have a fulcrum. It also assists in retracting the lips and the cheek. And exercises for gaining skill and control of instruments are described in Chapter 39. So go ahead, if you have time, and review Chapter 39 before you start preclinic, okay? Retraction, use a thin layer of water-based lubricant on dry or cracked lips. So we do have some Vaseline in each of the units for you to apply on your patient's lips. You're going to adjust the mirror position so the angles of the mouth are protected from the undue pressure of the shank of the mirror. So you don't want to rest this between the shank of the mirror. I'm sorry, this right here, the shank of the mirror against the teeth or the tissues. Okay? Then you're going to insert the mouth mirror carefully, maintain clear vision. You can warm the mirror with water or rub it along the buccal mucosa. And that the reason why warming it is so important is that it's going to fog up quite a bit if you don't do that. Okay. Just handle carefully during sterilization procedures to prevent other instruments from scratching the working end, and consult the manufacturer if specifications for sterilizing or disinfecting procedures that may cloud the mirror, particularly the front surface type. And then you always want to discard the scratched mirrors. Okay, now let's talk a little bit about explorers. Explorers do help us detect calcification, or excuse me, calculus, also irregularities in the tooth surface or margins of restorations. An explorer is used to confirm direct observation. So you see something and then you're going to run the explorer over it, right? So definition, I want you guys to know that these are used by tactile sense, and that means those vibrations that are going to go into your fingers that you're going to feel. And that's how you'll know when something isn't right, okay? So as far as defining the extent of instrumentation needed and guide techniques, you're going to use these, especially the curved ones over here. You're going to use those for subgingival scaling and root planing to see if the calculus has been removed. And also you can use them for detecting overhangs to see if they've been removed. And then you're going to evaluate, of course, the completeness of treatment. So when everything's all done, you think that you're completely done, you're going to go back over each of those areas where you felt the overhang or you felt the calculus, and make sure that you aren't getting that tactile sensitivity again. Okay, so Explorers continued. We're going to talk about the description. So the working end is a slender wire-like metal tip that is circular in cross-section and tapers to a fine, sharp point. The design, you can have a single-ended, such as this here, or you can have a double-ended. And then you can have a double-ended paired where they would just be opposite directions. Okay, so that would be this one here. Or you could have a double-ended unpaired, which means this is a different type of kind of explorer than this. Okay. Okay. So the shank can be curved or angulated, and that's what makes them a little bit different here, okay? And I'll try and bring in a couple explorers to class and see if we can take a look at them, okay? So our working ends are right here, very wire-like. Like our working end is right here, okay? Just these very tips pretty much. And then we have our shank, and the shank can be curved or straight, and that's just for ease of adaptation. So a curved shank is going to facilitate application of the instrument to proximal surfaces, mostly in the posterior, okay? And then, so this is the shank, right? We're coming from here all the way to here. We're going from that working end, just beyond that working end, to the handle. All right, here to here, and then here, not including that working end, to here. And like our mirror and all instruments, we can have multiple different kinds of handles. We're looking for something that's lightweight, something with a little greater diameter. And again, is it going to be single-ended or double-ended? All right. And I think that's all that we can, that's more the construction, you know, is it going to be single-ended, double-ended? These, you cannot replace the working ends like you can with the mirror. Really, the only one you can do that with is the mirror. Okay, let's go into a little more specific explorers and their uses. So there's a variety of explorers, as you have seen on the previous slide, or a couple slides ago. The function of each type is related to its adaptability to specific surfaces of the teeth at specific angles, okay? So certain explorers are used for the detection of occlusal caries, such as the number 23 or our shepherd hook is what we refer to it as. Others are designed to be adapted for examination of proximal surfaces for calculus or dental caries. And then certain ones are designated for subgingival use, such as our 1112 Explorer, whereas others can't be adapted subgingivally without inflicting damage to the patient's tissues. So explorers for deep pockets and inside furcations. Several explorers designed for very deep pockets and inside furcation areas are in current use, such as the Orban 20 and our 1112, which we use quite a bit. Another example would be, and it's not an explorer, but our Gracie 1112 can help get into those areas. So you're going to see calc removal instruments that are good for above the gum, and some that are below, good for below the gum, some that are good for furcations. So it all is dependent on the angle and the thickness and all that good stuff. All right. So for subgingival explorers, or pocket explorers, right, because our subgingival, you know, we can go slightly sub with other instruments, but when we have a diseased epithelium, a diseased pocket, or a diseased epithelium becomes a pocket, right? So in health, it's a sulcus. In disease, it's a pocket. So the shape of the explorer is going to be a little more angulated, and it's going to have a little shorter tip so that it can really cover all aspects without it poking into the patient's tissue. So you just keep that tip nice and adapted to the tooth. So instead of having a really long working end, it's going to have a little shorter working end so that you can angle it in that pocket. So features for subgingival root examination: back of the tip can be applied lightly to the attached periodontal tissue, which is nice because we want to get to the base of that pocket without lacerating any tissues. The short tip can be adapted to rounded tooth surfaces and line angles. So if we had a really long working end, it would be really difficult to get around that corner of the tooth or the line angle of the tooth. Supergingival use, it can also be adapted to all tooth surfaces, and especially useful for interproximal examination, supergingival, okay? And that's our TU-17 Explorer. Don't get too hung up on that. Most offices and places don't use that because it doesn't help detect pit and fissure caries, so that can be a little tricky. All right, then we have our sickle or shepherd hook explorers, and those are mainly going to be for our caries. Okay, we're going to be checking the surfaces of the tooth for any irregularities, any marginal restoration irregularities, okay? So, but we can't adapt that to the deep subgingival exploration because it has a really long working end. Then we have our pigtail and cowhorn, and the use for those is proximal surfaces for calculus, dental caries, or margins of restorations. The adaptability as paired curved tips, they're applied to the opposite tooth surfaces. And I know right now that just sounds like a lot of words, but we're going to try and take a look at this in class, okay, to help you better understand the differences between all of them. All right, so here they are again. They're in order, so you can see this long working tip, and you think of trying to get around just a little tiny corner, and that's not going to be good, right? So we want to use this for more of our flat surfaces and all of our super gingival surfaces. Now you can see these little pigtails here, how nice those would be to get around the teeth and into those interproximal spaces. Then we're going to skip over here to the 11, 12, and you can see how these are kind of curved, and those are really nice for subgingival, checking the subgingival surfaces. So the working end really is only about outside the red circle here is about that. So it's really easy to adapt around all the irregularities and everything. So one thing I want you to know is about the balanced Explorer design. And so with the middle of the tip being centered over the long axis of the handle. So this is what keeps it balanced, okay? The Explorer can then be positioned into a sulcus and pocket with ease and does not cause trauma to the gingival tissues. All right, so this is a your TU 17, and you will find this somewhat, we don't use it, it's not in your kits, but the dental assisting will use this a lot, okay? It's on the opposite end of the unpaired 23 Explorer, okay? Okay, so basic procedures for the use of Explorer. Development of the ability to use an Explorer and a probe is achieved first by learning the anatomic features of each tooth surface and its type of irregularities that may be encountered on its surfaces. So before we get into preclinic, you guys really need to go back and review the anatomy of the dentition, okay, of each and every tooth. The second step is repeated practice and techniques for application of the instruments. So that's what we're going to be doing in preclinic. The objective is to adapt the instrument in a routine manner that relays constant comparison information over the natural tooth surfaces. Okay, so when you're feeling it, you feel normal, healthy tooth surface, then you feel an irregularity. Okay, you know something's wrong, then you're going to start using your critical thinking. Is that decay? Is that calculus? Is that a filling? Okay. Now, use of sensory stimuli. Both explorers and probes can transmit the tactile stimuli from the tooth surface to your fingers. The fine Explorer usually gives a little more acute sense of tactile discrimination to the small irregularities than a thicker Explorer. So you want a nice, thin, wire-like Explorer. Now, probes have varying diameters, and the narrow types may produce a greater sensitivity. So thinner, narrower, those are the words you're looking for when you think of what's going to give you more tactile sensitivity. So 3 basic tactile sensations can be distinguished when probing an Explorer. These may be grouped as normal tooth surface, irregularities caused by excess or elevations in the surface, and irregularities caused by depressions in the tooth surface. So examination of these, will be talked about. So normal We're looking for a smooth surface of the enamel in the root surface, anatomic configurations such as the cingula or furcations. We're going to make sure we're rolling into there. Restored tooth surfaces, so small restorations or large restorations, I guess it doesn't matter, but how smooth are they? Okay, and you'll notice it makes a little different sound when it goes over a filling than it does over tooth surfaces. Irregularities, we're looking at the depressions and the grooves, also deposits. So, do we feel any elevations? Okay, so that's this category right here. And then we have irregularities, depressions, and grooves. So one is elevations, and the next is depressions. So types of stimuli, we have tactile sensations that pass through the instruments to the fingers and hand. And tactile sensations, for example, may be the result of catching on an over-contoured restoration, dropping into a carious lesion, or encountering an elevated deposit. So multiple things that we're going to have. But like I said, we're also going to use our auditory stimuli. And as an explorer probe moves over the surface of the enamel and cementum, a metallic restoration or a plastic restoration, we're going to get different sounds with each of those. Okay, so you're using the feeling in your fingers and the noise in your ear. Okay. All right, so supragingival procedures. When we look at our supragingival instruments, when we see the word supragingival, we're going to think of the use of an instrument coronal to or above the gingival margin. Okay? So, use of vision, supragingival exploration for defects of the tooth surface differs from subgingival in that when a surface is dried, much of the actual exploration is performed to confirm the visual findings. The exception are the interproximal areas because that contact is blocking our vision, right? Unnecessary exploration can be avoided with adequate light and air and proper retraction and the use of the mouth mirror. So multiple different things that are happening here. But just make sure you have a really good vision of it. Okay? Then we have facial and lingual surfaces. And you want to adapt the tip so the side of the point is always in contact with the surface. So you don't use the very tip of the instrument. You're going to use the side of the tip, and it's really important that you know that. Okay? Intact surfaces where remineralization may be going on must not be vigorously explored. Okay? So again, we don't want to break through that surface. Okay? Then the proximal surfaces, lead in with the tip onto the proximal surface, rolling the handle between your fingers to ensure adaptation around the line angles. So now, not only are you going up and down and across to check for irregularities, now you have to start rolling it in your fingers to get it around those line angles. Now, our subgingival, again, subgingival, you're thinking anything that's apical to or beneath the gingival margin. Essentials for detection of tooth surface irregularities. So this is a little bit different. Notice how we don't have visualization on here. We can't see this, all right? So what we're going to do is we're going to use a really light grasp and keeping our finger rest, right, so we don't slip off. And you're going to use, the side of the explorer tip while in contact with a tooth. Again, you're just using a very light pressure, Steps for use of subgingival explorer: with the tip in contact with the tooth supragingivally, hold the lower shank, the part of the shank that's next to the tip, parallel with the long axis of the tooth. I'm not going to get into a lot of this yet, because I want you guys to worry about the things that are a little bit more important right now. I want you to know that subgingival, we can have controlled strokes, 2 to 3 millimeters along a shallow improved adaptation of the instrument. So, it's just important that you're keeping the tip adapted to the tooth. And it's continuous strokes. Watch my cursor here. It's just going to kind of be like this, okay? You're just going to kind of, it's like a crayon, and you're just drawing a squiggly line, okay? So here it is. You can see this, you want to avoid that tip going to the base of the pocket, right? So you want to line it up a little bit better. But then you're going to just go up and down and up and down and up and down and up and down as you move along that tooth, okay? So you don't want to do the diagonal strokes any more than you have to, okay? Because we want to keep that tip more of the side adapted to it, okay? All right, let's talk about our periodontal probes. Early in the patient examination, the patient's periodontal disease status needs to be determined. The probe determinations provide major information for determining disease status of the periodontal tissues. Treatment planning varies depending on whether the condition is gingivitis, which may be reversible, or periodontitis, which is not reversible, okay? So this then would include a little more therapy. So types of probes, we have 2 general probes that are available for traditional or standard manual probes, and controlled force or automated probes. So yes, they do make automated probes that will take the measurement for you. They're technique sensitive, so I think a lot of offices don't use them. So what are some of the things you think you need to record when you are using a probe? I want you guys to think about that. When you go in and they take your measurements, what all do you hear? What are you observing? Okay, so they're observing multiple different conditions in the tissues. So they need different kinds of probes, right? There are traditional probes, okay, that are usually have color bands around them, and I talked about that in the previous video a little bit. And then probes that are specifically designed to assess furcation areas, okay? So our cylindrical long one, straight one, is not going to adapt into those furcations very well. So we want to use something that's called a neighbor's probe, and that is NABERS probe, okay? Automated probes were developed and researched in an attempt to overcome the problems in obtaining consistent readings from one clinician to the other. So the purpose and uses: a probe is used for the following purposes. Write these down. Purposes and uses. We want to classify the disease of the gingivitis or periodontitis. Okay. Determine the extent of inflammation in the conjunction with overall gingival inflammation. Bleeding on probing is an early sign of inflammation in the gingiva. We also want to make a sulcus or pocket survey. So examine the shape and the topography and dimensions of the sulcus or pocket. Then you want to measure the probing depths, evaluate the tooth surface, pocket wall, and chart patient locations and severity. Record other root surface irregularities discerned by the probe. Okay, so now we want to determine the clinical attachment level. And the determination of the clinical attachment level is described later in this chapter, and it's really important that you guys understand that. Then we want to conduct a mucogingival examination and determine the relationship of the gingival margin, the attachment level, and the mucogingival junction, along with the frenums. We also want to make other gingival determinations, such as bleeding on probing or suppuration on probing. We want to measure recession and determine the consistency of gingival tissues. All right, then we want to guide the success and completeness of treatment. So how did we do? We're going to have them come back in 6 months. How did they do? How did we do? Okay. And then continue to evaluate at all recare appointments. Okay, let's describe the manual periodontal probes. A probe is a cylindrical instrument. You're going to see this on the next slide. It's got a rounded tip design for examination of the pocket depth and topography. A probe has 3 parts: the handle, the angled shank, and the working end, which is the probe itself. Materials, they're made of stainless steel or plastic if there's an implant in there. Characteristics, they're going to have a straight working end. They'll have calibrated millimeter markings at intervals that are going to vary from design to design. Okay. Then we have some that have a curved working end to probe into the furcation. Do you guys remember what I called the furcation probes? They are called the neighbor's probes. N-A-B-E-R-S. Okay. So when selecting it, you want to think of what are your needs, right? So regular use of the same type of periodontal probes results in greater consistency of readings. Analysis of a periodontal probe in comparison with other probes are recommended. Important features to be considered when you're selecting a probe is the adaptability. The probe needs to be adaptable around the complete circumference of each tooth, both posterior and anterior, so that no millimeter area of the sulcus can be neglected. So flat probes require more attention to adaptation and are useful primarily on facial and lingual surfaces. Then we want to look at the markings. Markings need to be easy to read, so the pocket depth can be readily identified and measured, and no disease area is overlooked. Color coding contributes to reliability. All right, so here is an example of all of the different probes available to us, and you're going to have the marquee probe. There we go, this guy here, and the, let's see here, I have to think of what are, we have the marquee and the, UNC, where is it? I don't see it on here. Maybe the PCP UNC. Only ours goes up to 12, not to 15. I don't see it anywhere else on here. But the marquee probe is going to be the one that you're using for your traditional healthy patients, and then you're going to use the UNC probe for your boards. That's the one they require you to use. And it's going to have a few more markings, and those are for accuracy. All right, so here we go. I'm just going to mainly focus on the two that we use here. And this is our banded probe, and this is 1 to 3 millimeters. All right, 3 to 6, 6 to 9, 9 to 12. Okay. And then here we have our UNC 15, and it goes 1, 2, 3. Bottom of the color band is 4. Top of the color band is 5, 6, 7, 8. Bottom is 9. Top is 10, 11, 12. And that's where ours stop. Okay. So the purposes of the probe include assessing the periodontal status to prepare a treatment plan. Is it going to be traditional cleaning? Is it going to be perio maintenance? Is it going to be scaling and root planing? We want to survey the sulcus in the pocket. We're going to determine the clinical attachment loss, assess the mucogingival junction, other gingival findings. Guide treatment. It's going to show us exactly where we have the loss. Evaluate success and completeness of treatment. Evaluate continuing care and perio maintenance appointments. And then also aid us in the extraoral and intraoral findings. So here is our furcation examination. And so what probe would they be using here? Notice how it's really curved. So this would be our neighbor's probe. Okay. You can see with a standard probe, you aren't going to be able to get in there as well. All right. A furcation is a place where on a multi-rooted tooth where the root trunk divides into separate roots. It's termed bifurcation when there's 2 roots and trifurcation when there's 3 roots. So I want you guys to really think about this and how can you explain this to a patient. All right, so I always say it's like a tree. We have a trunk and then we have roots, right? And if you've ever seen a tree that's kind of washing out, you can see where the spaces between the roots are, right? So right in this area, okay? And you can imagine how much bacteria can get under that tree and into the tooth when that is exposed, right? So here we have our mucogingival examination. A probe is positioned for measuring the periodontal pocket. So our pocket, I am going to get my pen out here for this because I want to make sure you guys understand this, and I think I'll use green. All right, so a periodontal pocket, can't find it now. It gets so small when I use the pen, I can never find where it's at. Here we go. Okay, so our periodontal pocket is from here to here, right? To here. Okay. Now we know this is 1, this is 2, this is 3, the bottom is 4, and it's about 4.5, and we don't use fractions, so we're going to say that this is a 5, I don't know where my pen is, there it is. We're going to say this is a 5 millimeter pocket. Okay. Hopefully you're with me here. All right. So when we're looking at probing, we want to look at pocket characteristics. A pocket is measured from the base of the pocket to the gingival margin. Okay, so in this picture, and I just got to find where my little pen is here. There it is. Okay. So we're measuring from here, from here to here. Okay. And this looks like it's about 3. Okay. It's not quite touching that 3 line, but we're going to say this is a 3mm pocket or sulcus. Okay. But you can see how if we're moving along here, if we're moving along and we're walking in 1mm strokes, all of a sudden we're going to drop down here, right? And hopefully not down that far. And that's going to give us our pocket reading. So right there we have 3, but down in the base of the pocket on the, looks like the mesial side, we might get into a little more trouble there, right? So you're going to just walk it along with 1mm strokes. The depth varies around individual teeth. The periodontal, the pocket depth rarely measures the same all the way around a tooth. It can happen, but it's pretty rare. The gingival margin varies in position to the tooth. Proximal surfaces, you're going to go to the contact and then just slightly probe under that contact, kind of angling your probe in. Anatomic features of the tooth surface wall of the pocket influence the direction of the probe. So examples are that concave surfaces, anomalies, and shape of the cervical third and positions of the furcations. So all those can contribute to it. Now, evaluation of the tooth surface during the movement of the probe while it's going up and down, it may feel that calculus and tooth irregularities. The information obtained is used to plan the scaling and root planing appointments. Factors that affect probe determinations include the probe, right? So you want the most accurate, which the boards believes is the UNC, because, you know, when you have banded ones like the one in this picture, you know, it gives a lot for interpretation. How far in the middle are you? How far, you know, because you can't see. Let me get my pointer out again. This pen isn't the best tool for me. So you can't see all of this. All you're seeing is what's left. Okay? At the same time, patient discomfort and trauma can also be an issue, and we want to make sure that we minimize that as much as possible. So just using a really light grasp, going till you touch the base and coming back up. Severity and extent of periodontal disease. With application of light pressure and secure finger rest, the probe is inserted under the gingival margin and held against the tooth as it passed along the tooth surface to the attached tissue level. Diseased tissue offers less resistance, so that with increased severity of inflammation, the probe inserts to a deeper level. All right, calibration. Calibration must be accurately marked, otherwise readings may not be accurate. So you need to calibrate amongst each other. Thickness, a thinner probe slips into a narrow pocket more readily. So you want a nice thin probe if possible. And then the readability, aided by the markings and the color codings, but you still need to know like what is above that, because you aren't going to see what's below it. All right, and so you want to stay in line with the long axis of the tooth. And here it's right here, and here it's here. So this is a nice shallow sulcus. This is a deeper pocket. Okay, so preliminary assessment prior to the examination, we want to make sure that we have a thorough medical history. We want to reduce the risk of bacteremia, so make sure that the patient has pre-medicated before probing. If they need to be pre-medicated and you probe first, you're introducing the bacteria into their system, so you want to avoid that. Always pre-med before probing. Dental and psychosocial history. Document the dental history, including oral self-care habits, preventive dental history, and their chief complaint. Psychosocial history may include information such as whether or not they're married, what their living situation is, their financial situation, work habits, diet, substance use, stress, and social health or oral health literacy. Psychosocial factors are taken into consideration when planning treatment and setting treatment goals. Now, our vital signs always need to be taken and documented, right? Vitals should be done at each and every appointment. Then you will also want to do the intra and extraoral exam, including any risk assessments, which are in chapters 27, 19, 12, and 34. We want to review our radiographic findings, right? What is our bone level? Is there decay in the area? Is it going to be sensitive to them? And the dental examination, how do their restorations look? Are there overhangs? Are there rough surfaces? Are they missing teeth? Okay. And then we have hard calculus and soft deposits. So here's our dental calculus. You can see this is all subgingival. Notice how it's all a much darker color. And then this here is supra on the root surface, and then it goes up to the crown. And here is plenty for you to take a look at. Now this up here, this is stain along with calculus, okay? And you can see how beautiful they look when they're all cleaned up. All right, EOIO findings. Look for things such as fibromas here, or ulcerations, which are right here. Cracked lips, or any herpes simplex virus here. Look for these wart-like protrusions. That could be HPV. Okay. And then any of these lumps or bumps can be measured, right? Using our probe. Okay, so parameters of periodontal care. Grasp the probe with the modified pen grasp. So it's very similar to holding a pen, but we're going to get into the grasp a little bit later. What I want you to know is that you need to have a solid fulcrum. You want to hold the side of the instrument tip flat against the tooth near the gingival margin, and then you're going to gently insert it under the gingival margin. Advance the probe to the base of the pocket. You're going to slide the probe tip flat against the tooth surface till you hit that junctional epithelium, and take your measurement and keep going, walking 1 millimeter apart. Okay? And we'll get into that again in preclinic a little more. Okay, reading the probe measurement, know what the markings are above it, because once you get to that gingival margin and start inserting it, you won't be able to see what's below it. The comparison of pocket measurements using probes with different calibrations is shown in chapter 20. When the gingival margin appears at a level between probe marks around up to the higher of the two, so a couple slides ago you saw me mark it and I said it looks like it's a 5. Even though it wasn't up to a 5, you're going to always run up to the 5. around up to the 5. Probe stroke, again, nice and light, moving 1 millimeter apart. It is called a walking stroke. And, we had a nice picture on that earlier. Anterior teeth, you're going to initial insertion may be at the distal line angle or in the midline of the tooth. Otherwise, when you're probing all other teeth, you're going to start at the distal line angle, work your way into the distal, and then work your way out and coming around. Again, a lot of that is for preclinic. All right. So you want to be parallel to the long axis of the tooth. So when we have an accentuated concavity of the cervical third and widespread roots of the primary molar, they do complicate probing and probe placement. Probe may encounter the root, so the permanent tooth with a little less convexity of the cervical third and roots that are less widely separated make it a lot easier. Okay, and here we are probing into that contact. This marks the contact area. You're going to get to that area, you'll be standing up, and then you're just going to angle it a little bit. Now remember, this is the call, right? Okay, so comparison of probe readings, these should all be the same, but you can see how they all look differently. So the walking probe stroke, slide the tip of the probe, the side of the tip of the probe is held in contact with the tooth. From the base of the pocket, you're going to probe up and down in 1 to 2 millimeter strokes as it's advanced in 1 millimeter steps. Okay, when you're recording pocket depths, you're moving in 1 millimeter movements. You're raising it up 1 to 2 millimeters, but moving it across the tooth at 1 millimeter walking steps, right? So we're actually going to take 6 measurements per tooth. So here is, I guess it depends on where you're starting, but we're going to start on the distal here, okay? So we're going to start here. We're going to work our way back, work to the contact, and then we're going to tip our probe in, and whatever the deepest pocket is from here to here is the number that we record. Then we go 1 millimeter apart, okay, all the way across the buccal, and then that's going to be our second measurement. Then we're going to go to the mesial, and we don't have to take our instrument out. We're just going to start angling it in there. Contact, tip it in, whatever the deepest measurement is from here to here is now our probe reading. So you do that all the way around the tooth, okay? All right, let's talk about the clinical attachment level. This is includes a little bit of math, okay? So, let's see here. Attachment level refers to the position of the periodontal attached tissues at the base of a sulcus or pocket. It is measured from a fixed point to the attachment areas, whereas the periodontal pocket depth is measured from a changeable point, okay? The rationale is a loss of clinical attachment, so that's our CAL, is a primary clinical feature of periodontitis as the junctional epithelium migrates towards the apex. So the procedure is going to be first selecting a fixed point. The CEJ is going to be our fixed point unless it can't be detected because of abrasion or because of a crown or something. margin of the permanent, so then you'd use the margin of the permanent restoration. So measuring in the presence of visible recession, the CEJ is visible directly. You're going to measure from the CEJ, that's on the tooth, to the gingival margin, right? The top of the gums. The clinical attachment loss is calculated by adding the pocket depth to the GM to CEJ distance. Measuring the CEJ is covered by the gingival margin, and you're going to slide the probe along the tooth surface into the pocket until the CEJ is felt. This is the CEJ to the junctional or gingival margin measurement. Subtract the distance from the CEJ to the GM from the total pocket depth. Okay, so let's move on to our next picture. I think this will become a little bit more clear. Okay, so let's talk about our clinical attachment loss here. In A, we have a 10 millimeter pocket. Okay, we're right about here. Okay, and our CEJ is at about 6. Okay, so we subtract the 4 from 6 to get our clinical attachment. CAL. Okay, so in this one, we're going to call it 6. In this one, we see that it's at 6. There's some recession, but that doesn't matter because our measurement is always going to be from here, to here. Okay, so we still have 6 even though we have recession. So here it's 6 also. Here they're just measuring the inflammation. All right, and then D is our nice healthy, or not healthy, but our normal situation where we don't have to add or subtract. There's no recession, there's no enlargement. So here we have 6 also. So we have 6 millimeters all within different situations. Okay? A has inflammation, B has recession, and then D is just fine. Or I shouldn't say just fine, but the gingiva is at the CEJ still. But we still have a 6 millimeter pocket, so it is definitely not fine. All right, so now we need to look at our mucogingival attachment. And the purpose of this is to detect the adequacy of the width of attached gingiva. So to locate frenal attachments and their proximity to the free gingiva and to identify promptly the mucogingival junction. So we're going to use the tension test procedure. All right, you guys want to know what the tension test is. On the facial, you're going to retract the cheeks and lips, and you're going to move them laterally by grasping them with the thumbs and index fingers. You're going to move the lips and cheeks up and down and back and forth, creating tension between the attached gingiva and mucosa to make the mucogingival junction visible. Follow around to the molar area to the right and then to the left, and then both the maxillary and mandibular. You want to observe all of those frontal attachments. On the lingual, you want to hold a mouth mirror to tense the mucosa on the floor of the mouth, gently retracting the side of the tongue so that the mucogingival junction is clearly visible. Then you're going to request the patient move the tongue to the left and to the right and to touch their palate. And that's to make sure there isn't any ankyloglossia, right? Then they're going to fold and wrinkle. You want to do a fold and wrinkle test. You're going to retract the lips gently, but not to the point of tension between the attached gingiva and the buccal mucosa. The periodontal probe is oriented horizontally at the MGJ, and gentle pressure is used to fight or wrinkle the mucosa towards the gingival margin. This test can be used if the mucogingival junction cannot be readily visible. Measurement of width of attachment, you're going to place the probe with no pressure on the external surface of the gingiva and measure from the mucogingival junction to the gingival margin to determine the total width of the gingiva, of the attached gingiva, of the gingiva. Then you're going to measure the pocket depth, and you're going to calculate the width of attached gingiva by subtracting the pocket depth from the total width of the gingiva. So what areas are most at risk for the mucogingival conditions? Areas of recession with little keratinized gingiva, the base of the sulcus or pocket, is near the MGJ. When a pocket extends to or beyond the MGJ, the probe may pass through into the alveolar mucosa when probing the pocket. Absent or narrow attached or keratinized gingiva there's going to be an absence of the attached gingiva. And then the anatomic features such as tooth position and frenum insertions we need to be concerned about. So here we see that there's some recession, right? Okay, so we see that there's some recession right here, and that's concerning. Then if we pull out the lip, you can kind of see the mucogingival junction like this, so you know that it's very narrow there. And the problem is that then bacteria, there isn't much room for error here. I want to make sure that they're able to keep that nice and clean so it doesn't invade that mucogingival junction. So you're going to measure from the top of the gingiva to the mucogingival junction, and then you're going to subtract the pocket depth because that free gingiva around that isn't attached, right? Okay, so here's the procedure. Here they have, we'll say 5, and here they have, we'll say 3. Okay, so 5 minus 3 is 2. So they would have 2 millimeters of attached gingiva. You do need to know how to do this for your test. You need to know how to do all these different measurements for your test. All right, mobility. Let's talk a little bit about that. Mobility, because the nature and function of the periodontal ligament and teeth have slight normal mobility, we do need to still consider abnormal or pathologic mobility when it exceeds the normal. Increased mobility can be a clinical sign of periodontal trauma from occlusion. We talked about that a little in Chapter 17. Procedure for determining mobility, you want to position the patient for clear visibility with good light, stabilize the headrest. Then you're going to use 2 single-ended metal instruments, 1 for each side. You want them to be blunted, and you're going to use those back and forth. You don't want to use your fingers because you do have a little give in your fingers. So let's take a look at this on the next slide, how you're going to do that. Okay, so we have N, which is normal, okay, and then we have 1, 2, or 3, and these can be in Roman numerals or normal digits. So 1 is going to be our normal, 2 is going to be slightly mobile, which is greater than normal, so that's usually up to 1 millimeter. And then 2 was going to be greater than 1 millimeter, but less than 2 millimeters. And then 3 is going to be greater than 2 millimeters. So severe mobility, it's going to move vertically and is depressible within the socket. So not a lot of attachment there. Fremitus means that there's palpable vibrations or movement. So in dentistry, fremitus refers to the vibratory pattern of the teeth. A tooth with fremitus has excess contact with its opposing tooth. Okay, the test is used in conjunction with the occlusal analysis, but because fremitus depends on tooth contact, determination is made only on the maxillary teeth. You can't feel the mandibular teeth. So you're going to sit the patient in the upright position, gently place the index finger on each maxillary tooth as at the cervical third, and then request the patient to close their teeth together in a functional occlusion. And then you're going to say tap, tap, tap. And if you feel vibrations, then we know that there's some fremitus there. So degrees of fremitus, we have normal, that's without any vibrations. And then we have 1, and these are measured with plus signs, or recorded with plus signs, is 1 degree fremitus. So only slight vibrations can be felt. And then 2 plus signs is going to be 2 degrees of fremitus, and the tooth is clearly palpable, but movement is barely visible. And then 3 is, so here's our fremitus test. You have the patient just tap, 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 and see if you feel any vibrations up here. All right, furcation examination. Again, we're going to use our neighbor's probe, NABERS. But first we need to talk a little bit about the anatomical features. So remember, we have 2 rooted teeth in the mandibular molars and 3 rooted teeth in the maxillary molars. Primary mandibular molars, the roots are going to be a little more widespread. So we want to detect furcations early on, and what's going to happen is as you're probing, you might feel a little bit of an indent, and then you would want to record that. So points of access, measure periodontal pockets at points of access for each bifurcated or trifurcated area. Position of the gingival margin will vary, so sometimes you can see it and sometimes you can't. So let's talk a little bit about our furcation grades. Grade 1 would be just the beginning of involvement. So a probe can either enter the concavity of the furcation, but the bone between the roots is still in contact. Okay, so that's where you're just starting to feel a little bit of an opening, kind of that where that root trunk starts to indent. Okay, then we have grade 2, which is where you can actually go down under there with the probe, but you can't get all the way through. And then 3 is going to be where you can get all the way through, but the gums are still kind of up in this area. Okay, so think of this, the gingiva being up in this area. Grade 4 is the same as 3, only you can see through. You have enough recession, and that's what this tooth is showing. Okay, so complications, anatomic variations that complicate furcation examination are focused are fused roots. Anomalies such as extra roots or low or high furcations. And here's our neighbor's probe. This is what we use to probe our furcation area on multi-rooted teeth. And you can get it color banded or not. All right, here's our class 1 concavity. You can just kind of feel it in the trunk of the tooth. Class 2, we're going to see that probe be able to go into that concavity. So remember, if the probe can get in there, you are expected to keep that area nice and clean. So once you get a patient with a root furcation, you're going to want to start teaching them how to clean it, right? Because they can't access it without being taught. Now class 3, it's going to go all the way through. All right. And what does that mean when it's trifurcated? It means the maxillary molars probe touches the palatal or lingual root. Okay, so you go in here and they're going to feel, if this is a maxillary, they're going to feel the palatal root. And then class 4, you can see the difference between class 3 is that now our gingival level is down here and we can wave to our neighbor here. Furcation is visible clinically due to tissue recession. Okay, bone level. Let's talk a little bit about that. Normal bone level, the crest of the interdental bone appears to be from 1 to 1.5 millimeters from the cEJ. The bone level in periodontal disease, the height of the bone is lowered progressively as the inflammation is extended and bone is destroyed. The shape of the remaining bone, horizontal bone, is when the crest of the bone is parallel with the line of the cEJs of the two adjacent teeth. When inflammation is the sole destructive factor, the bone loss usually appears horizontal. When the amount of remaining bone is fairly evenly distributed throughout the dentition, the condition may be described as generalized horizontal bone loss. It may be designed either by millimeters from the position of the normal bone level or by percentage. When bone loss is confined to special areas, the condition is described as localized horizontal bone loss. Okay, so maybe it's just between two teeth. Angular or vertical bone loss is the reduction in height of crestal bone that is irregular. The bone level is not parallel with the line joining the two cEJs. So it creates kind of a V-shaped mesial bone loss on the mesial side. Let's see here. Angular bone loss is more commonly localized, rarely generalized. When inflammation and trauma from occlusion are combined in causing destruction and irregular shape of the bone may appear with angular defects or with vertical bone loss. Now let's talk about the crestal lamina dura. It's the white radio-opaque continuous with and connects the lamina dura about the roots of the two adjacent teeth. Covers the interdental bone of the two premolars. That's what it looks like in normal, okay? So in evidence of disease, that lamina dura, it gets kind of blurry on the radiographs, okay? The furcation involvement, again, normal bone is going to fill the area. Evidence of disease, it's going to be more radiolucent, right? It's going to be darker. Early furcation involvement shown in the second molars. Remember, the second molars don't have as long of a trunk on their tooth, so this is maxillary and mandibular. The trunk is shorter, so that means that you're going to get furcation earlier with clinical attachment loss. Maxillary first premolar furcation involvement cannot be seen in a radiograph with the correct vertical and horizontal angulation because the roots are superimposed, right? Those roots are the buccal and lingual rather than mesial and distal. So when we're looking for evidence of disease, widening and thickening, angular thickening or triangulation, widened only near the coronal third, near the crest of the interdental bone. Complete periodontal ligament thickness along an entire side of the root to the apex or around the root. Sorry about this. When viewed at different areas, the ligament space may reveal varying thickness, thus showing the disease involvement is not consistent around the entire root, and that the other structures are superimposed. Okay, so here we go. Here's our normal bone level connecting our CEJs. Here, we're going to see our angular or vertical bone loss. Okay. Here's our angular. Here you can see some horizontal bone loss also. But vertical, notice there's no lamina dura here. And you're going to see this periodontal space starts to widen, is wide here, but it's absent in these. Okay, other radiographic findings. Any other radiographic findings related directly or indirectly to the periodontal involvement and contributing factors are noted and recorded. Okay, you always have to record them. Certain findings have a direct relation to dental hygiene care and instruction, particularly local factors that contribute to food impaction and biofilm retention. So calculus is our gross deposits, primarily those on proximal surfaces, may be seen on radiographs. Radiographs has very limited value for calculus detection. With an Explorer, it's needed, so you want to assess it with an Explorer, okay? Overhanging restorations, some proximal overhang margins can be seen on radiographs. Again, make sure you're still using your Explorer. Dental caries, we are going to see and you can refer back to chapter 16, but those can be seen on radiographs. And then our relationship to periodontal pockets. Because a pocket is measured from the gingival margin to the base of the pocket, both of which are soft tissues, pockets can't be seen on radiographs. Probing is necessary to identify pockets. All right, documentation. Documentation is in the permanent record for a patient with a gingival or periodontal condition needs to include a minimum of the following: findings of the clinical observation and the use of periodontal probe, sulcus and pocket depths, attached levels, status of furcations leading to the dental hygiene diagnosis, mobility, fremitus, occlusal problems, and other findings that will tie the complete oral plan for the dental hygiene care plan into the overall major treatment plan for dental care with the dentist. Sample progress notes can be found in chapter 20-2 or in box 20-2 found in chapter 20. Make sure you review those. You can go into the lab, into the computer lab, and start typing some of those up just to get used to and stay fresh on your EagleSoft. All right. Last slide. Factors to teach the patient. We need to teach the patient the need for a comprehensive examination, the value of the various components of the comprehensive exam. That includes recession, pockets, width of attachment, bleeding, pus, radiographic findings, all of that. So it's all inclusive, right? We're involving everything we just did. And then we need to teach them why bleeding can occur when probing, the relationship of periodontal disease measurements to normal sulci, and the significance of our periodontal findings. So you always want to let them know their periodontal classification. All right, thank you very much. If you guys have any questions, please let me know.